it's always tracking on filtering through past experience. Neuroarchaeology. The age at which an adverse event takes place will influence the neurodevelopmental impact and therefore the resulting functional consequences. We've had some talks before about adverse events. Good old Kaiser did the 17,000 database and looked at mental illness and physiological illness based on adverse events, especially early in life. So developmental history of adverse experience is crucial to understanding current functioning and includes the developmental review of adverse experiences and the buffering effects of relational health. Because how do we get safe? Being in close relationship. Human beings are social creatures, and the neural states which mediate social interaction, communication, empathy, and the capacity to bond are all shaped by the nature and quality and timing of early relationships. The neural systems mediating the stress response, reward, procreation, reproduction, social affiliation, and communication are all interrelated. Indeed, they share the very same fundamental neurotransmitter networks and brain regions. So again, we see the incredible connectivity in the brain and the plasticity of the brain in the early 4 years to either be protected with corrective attachment and bonding or not be protected without that. I think that's the same slide. Maybe got two, the same thing. Okay. The emotional state of the mother's brain directly shapes the baby's brain. If the mother is feeling a lot of love with the child and is attuning to the child, versus if she's depressed, if she's angry. They say that the mother's frontal lobe becomes the child's frontal lobe. Maybe that's too simplistic, but that kind of safety and bonding and attunement decrease when the caregiver is overwhelmed and distressed. There's a heterogeneity of response patterns, adaptive changes in cognition, affect, behavior, neurophysiology, and just physiology. So how does the baby respond when the mother is less than happy? Even in the womb, they've measured how babies respond, and I understand the second trimester for mothers is particularly vulnerable, that there are not the protective factors there are in the third trimester if the mother is depressed. So this can all change the baby the moment the baby is being formed. So a loving caregiver teaches the child to soothe themselves, and a lack of a specific pattern of experience, such as nurturing, during the developmental early years results in abnormal development of the core brain functions. Abnormal development in brain systems which sense, perceive, process, interpret, and act on information related to that specific experience or input. I'm just recalling that Bruce Perry was the lead researcher and the lead therapist with the Branch Davidian children. There's such a huge number of children who had such abnormally high heart rates even 6 months after they were taken out of the system that they were in. And you know, the long-term effects of these early experiences, again, on the brain and on the entire physiology. So the NMT process involves assessing the timing, nature, and intensity of adverse events. The timing, nature, and quality of buffering relational health is assessed as well, because the two are in a balance and one can counteract the other. An estimate of developmental risk is obtained at various times during development by combining the adverse experience and the relational health scores. So we're looking at both of those and coming up with a number. Current relational health is very important to assess. A major factor in healing appears to be the nature, quality, intensity, and stability of a person's relationships. The NMT assessment includes a simple metric that looks at current relational health. The score is a key indicator of outcome, with good relational stability predicting positive outcome and poor relational health predicting poor outcome. The key indicator of brain organization in neurophysiology is function. So by creating a simplified construct, the brain map, assessment of key brain-mediated functions can help localize neurodevelopment vulnerabilities and strengths. If you think about my daughter, I noticed right away when we put her in the swimming pool, she was not able to regulate her body temperature. She could go in the swimming pool and 2 minutes later come out completely frozen and just shivering. So that's something at the very lower level of the brain that was not operating well for her, regulating her body temperature. This localization then helps direct developmentally sensitive interventions. So if we're really changing the brain, let's change it in a way that's developmental and that's sensitive to the specifics of this particular person. The current mapping process involves a web-based menu-driven review of various brain-mediated functions. It's real expensive to do the training, and it's wonderful stuff. The resulting map creates a visual representation. It's useful for teaching, for treatment planning and tracking outcomes. And clinical implications are that in order to effectively influence a higher level function, such as speech communication, lower innervating networks must be intact and well regulated. Restorative neurology has as its basis that a repetitive motor activity is used to recover from a stroke. I remember my stroke of insight with Jill Bolte. I'm sure she did quite a bit of repetitive activity to open up again her left brain. But this suggests that therapeutic massage, yoga, balancing exercises, movement, somatosensory activities that organize, regulate, input would likely diminish anxiety, impulsivity, and other trauma-related symptoms. So we're going down into the level of the brain that is not well organized, that has not been given the repetitive needs for stimulation, and has fully developed. And I'm pleading right now with authorities up in Vermont where my daughter is, and she's had so much in the way of good services there, for more of these kind of activities since she seems to need that, and she still suffers from a lot of trauma effects. So the therapy...
If I could chime in, Carl, as you go over this particular piece, one of the things that I think I saw in one of the videos I actually show, but it could be, I read it somewhere, but a guy who had a stroke, and the son, very determined to get the father to walk again because he couldn't walk after the stroke, said, let's go back to basics. How did you learn to walk? And you learned to walk by first crawling. So he got his father on the floor and started him crawling, and then, you know, as if he was like an infant, and took him through that whole process you're describing, that repetitive motor activity, but sort of re-teaching the brain how to do the things it had lost through the process of stroke, and was successful in getting his father to walk again.
Yeah, it's I'm really indebted to many physical therapists and occupational therapists who work with my daughter, and one of them is actually now in Fort Bragg, and she's in charge of a team of about 30 physical therapists. And I remember she told me at the very beginning of assessment, she said, you know, your daughter is 14 years old and she has a primitive startle response similar to that of a 6-month-old baby. I said, really? And yep, it was right there. And we did a lot of sensory integration therapy with her. We did interactive metronome. It was all very, very helpful in teaching her to self-regulate, really very helpful. So therapy then seeks to change the brain. We have targeted therapeutic efforts that remediate the effects of neglect and trauma. And neglect is a big one. I think that's partly what you get when you get a child from an orphanage. My daughter's visual ocular system was not very developed because she spent a lot of time looking at the white ceiling from being in a crib and not being held and touched. So she had severe problems with tracking and having her eyes track on a page and do it smoothly. So these are the core elements of positive developmental, educational, and therapeutic experiences. First, it's relational and it's safe. Second, it has relevance. It's developmentally matched. Third, it's repetitive. There's patterns that need to be repeated again and again and again, and many of those patterns have to do with interactive communication. It must be rewarding or pleasurable. We are behaviorists. It's got to be rhythmic, resonance with neural patterns. And it's got to be respectful of the child, the family, and the culture. So this is his core message, is that we need to use these rewarding ways that are respectful and are brain-based appropriate, developmentally brain-based appropriate. This is a picture of me and my daughter when I went to the Ben & Jerry's Festival 2002. She was about 10 years old, and she was doing pretty well. I think she had braces on her teeth at that point. So she did get better in many ways. This is a picture of beginnings with me. I went to Seaburn Fisher and got the Neuro cybernetics system, and as you know, we had to use huge computers back then and a huge clunky monitor, and this was 3D Pac-Man that we did. I'm looking on the left, of course, at the raw brainwaves, and looking at her on the right with playing Pac-Man, and we did probably over 100 sessions, and those sessions were guided by a brain map about halfway in because I realized I needed it. We'll get to that later. And here's her current horse. She has an 8-year-old thoroughbred horse called Smokey, and I got to see her last summer over in Woodstock, New York, taking first place. Many girls had $100,000 horses, and her horse was a lot less expensive than that. But she's quite an equestrian, and being from Kazakhstan, it's kind of in her blood. Now, I'd like to go to some overheads that, okay, can you see my screen, folks?
Yep, we can see it.
That?
We can see it, Carl.
Yep. Oh, great. Okay. So this is a little bit about attachment. You know, Vermont was so big on attachment and bonding, and we had Dan Hughes come down from Maine talking about the experience of building attachment with a child who has an attachment issue. And you can see the cycle here. The caregiver makes connection through the smiling, the eye contact, the holding, rocking. I remember hearing the high-licking mama rat is the one that you want in the rat culture. So then the child can feel the positive trust building. Caregiver responds by soothing, feeding, changing. The child feels comfort, and then this whole cycle revolves again and again. And that's the proper way for attunement and co-regulation of affect between caregiver and child. So that's the best case scenario. Now, when they don't get that, we have reactive attachment disorder, which we talked a little bit about on this program. This is Dan Hughes' overview and his definition of persistent failure before the age of 5 to make those social interactions with resulting lacks of affective attunement. He's big on attunement, and also excessive shame. My daughter jumped into anyone's arms, always kind of lobbying herself. Even at the airport, she jumped into another man's arms and was always meeting people and smiling and getting, because you never know when you have an attachment issue if you're going to need a new friend. And I would say this dissociation or hypervigilance has been a chronic issue for her. She's defined right now as being on the autism spectrum, which is good for funding, but the people in the autism community really don't understand trauma, so we've had to do a blend of trauma specialists and autism specialists, and frankly, the trauma specialists need to be much more executive. Here are some of the risk offsetting factors. This is from a camp called Wadiko, Hugh Lightman did in Massachusetts, and he talked to parents about many of the children in the camp were adopted. Some of the offsetting factors on the right, obviously, is good parenting, which she had from the age of 6 on, consistent nurturing, easy temperament, intelligence, resiliency, no learning issues. Congruency between parenting styles and stable early history, all that would be great if that were there, and that, of course, offsets the risk, which my daughter had numerous risk factors, including, of course, severe illness when she was 4. She almost died, was in a hospital for a couple weeks with some sort of urinary tract infection. Plus she was in the orphanage and was really enlisted to be a caregiver to younger children. She was 6, the younger children were 3. So she was up late at night reading them stories and calming them down. It's interesting that she didn't really get to be a child. And this is a little bit that came right from Bruce Perry about the brain areas and the expression for arousal. And I just thought it was interesting that there's a difference between boys and girls in the expression in the brain area, with girls doing much more dissociation. And Bruce does talk quite a bit about the norepinephrine, serotonin, dopamine connection going throughout the brain, you know, from the bottom to the top and changing the brain. So we've got hyperarousal here, and all the symptoms of hyperarousal, overarousal, and then we've got dissociation and the difference in the chemistry in the brain. Dissociation is probably more frequently what my daughter goes for, but there are times when she's highly aroused and she'll run for 7 or 8 hours, and Vermont's been great about supporting her. They know her well in the community, and but that frequent dissociation has been a real chronic issue for Christine. It's one that she obviously needed maybe early in life. She was taken home on weekends by caregivers, and who knows what happened, but we suspect more than physical, probably sexual abuse before the age of 6, so really tough stuff. All right, let's get back to number 2. Now this is actually from a document. It was a 25-page assessment. And I just want us to look at the 3rd paragraph. As previously stated, now can you all see this? Is this good to see? Do I need to make it bigger? Rob?
It's very clear and readable. Very clear and readable. And we can see the yellow outline.
Okay, so I'm looking at this 3rd paragraph. During the prenatal period and few years, the majority of the brain development is completed disproportionate to the rest of the person's life. It's interesting that the brain's huge development is in those first 5 years. The brain develops sequentially from the brainstem up through the cortex, regulates sensory and other basic physiological functions. This explains why people with developmental trauma often have sensory regulation and emotional regulation issues, as does Christine. Fortunately, research and experience has shown that these patterns can be rebuilt or built later in life with appropriate intervention. The interventions must be designed to aid those basic capacities before working on higher order functions such as relational and cognitive capacities. What this means is in our traditional, more talk-based therapies are alone not effective for children or people who first need to be engaged in repetitive activities that can serve to regulate these primary functions. As the process is to replace current maladaptive neuro connections with new connections, the process must be repetitive and carefully delivered. I thought she just nailed it. She's a brilliant, there's just a lot of brilliant therapists in Vermont. I'm just so glad that we moved to Vermont from San Diego, California, and got all kinds of therapy that they're very committed to.
I was going to say, Carl, as you're switching slides, that this model you're describing, too, is very similar to Pat Ogden's model, a psychomotor approach. Again, looking at, this chart is a great chart because I think it helps explain everything in greater detail because if you don't have the bottom developmental things right, you're not going to get to the top easily. But Pat Ogden, who also did a chapter in our book, talked about a sensory motor approach where you've got to do all those things that you're describing. And she's up there, she doesn't work with Bruce Perry, but she's up there with Bessel van der Kolk and that group, big trauma group up there in Boston. Yeah.
The guy who's actually working with Christine was saying he probably respects of them all Pat Ogden's method, and there's numerous people who have been trained by her, and I'm just so glad. I mean, isn't it a great age that we live in, that we have this incredible understanding and options in treating really tough trauma? So this is
right.
Bottom up. You can see the more primitive brainstem functions are here in the pink area. Then we're moving up to the cerebellum for the yellow area. It's interesting. My daughter had excellent large motor functioning and coordination, but very poor fine motor skills. Her sleep has never been good. Her dissociative stuff has been happening a lot. So that cerebellum, it was just so interesting. Right from the start, she loved to swing, and I would swing her, and, I'd been a PE teacher, so I could see she needed to move a lot. And I'm just so glad we eventually got sensory integration assessment and a lot of very specific therapy that was very repetitive motor-based. So then up here, of course, is the more midbrain, moving right up to the frontal cortex and the cortex. You can see it's really a learning-based, skill-based paradigm that he's got here. So this is the basic overview, and this was applied to my daughter Christine with incredible skill. I'm really I'm amazed at how well they were able to use the data, and this is the beginning of some of the data for her. So looking at the metrics, it shows her interuterine, perinatal, infancy, early childhood, childhood, youth, and early adult developmental risk factors in the red, and resiliency factors with relational health being in the green. Let's bump this up a little bit bigger. And then you can see that the developmental risk was really high at the beginning of life. She came from a town where it was, they changed the course of a river with a nuclear bomb, and there were numerous nuclear events that were just kind of happened in her town, which was a military town. So it wasn't when she was born at 80, it was like she was born in 89, so this happened in the late 50s, early 60s. But again, the environment was terrible there. And you can see then the high risk factors until finally in her early youth she was adopted and she was in a safe environment. But it shows that the scales here on the right, adverse events versus relational health. And it really didn't start to balance until she was an early adult. Okay. So here are the four areas: the sensory integration, self-regulation, relational, and cognitive, and then some ratios of how that affects the cortical areas. You can see on the left is the client in the very light blue. Typical age, I think she was 23 when she was assessed here, would be up into the high 90s, mid-90s. And a mature individual would be in the same level because she's essentially, with a female brain at 21, she's fully adult. So we're going to get to recommendations based on those categories and her age at this time and her maturity compared with norms. So they've got three categories: essential, therapeutic, and enrichment. I'm concerned with the essential ones because those would be scores below 65%, which most of hers were. It was just so wonderful to see this in black and white and to have the understanding that it brought. Here's the sensory integration needs, and again, the need for swimming, running, rocking. I mean, she's done every kind of sport you could name and loves them all. And unfortunately, right now, she's not moving very much at all. And there isn't really anyone who's encouraging that, so we're going to be making that a big priority in our next meeting. Self-regulation, obviously. She started needing blankets, weighted vests. She's needed breathing, and she's gotten a little of it. She's always been around animals. We've adopted a couple dogs that were from the Humane Society, and all of her horses are basically hard luck cases. That it's kind of a homeopathic remedy. You adopt bring into your life a horse that's been wounded, and pretty soon you're working with your own issues. Relational is probably the toughest area. She met the criteria for autism when she was 16, and I thought, oh no, now we have another category. But it was a very good funding category, and it's just a category in terms of relational skills, which are very poor. She doesn't seem to get it, and especially being around the barn with girls, it's particularly powerful. That she just doesn't understand when sometimes girls are talking about a relationship-oriented situation. She had some art therapy and some play therapy at the beginning, but really attachment therapy was much more specific to her needs. And cognitively, obviously, her frontal lobe has always been slow. There's been a ton of alpha there. You'll see later the QEEG data. And this is the most kind of confronting of them all. It takes right from the beginning, what are the brainstem areas of functioning and what are the typicals, and it really breaks down the detail. Notice here the temperature regulation, her attention and tracking is still very, very low. It's right down there. The cerebellum, primary sensory integration is still a 3. Dissociative continuum is a 2. Fine motor skills are very, very hard for her. At a show, you know, you have to braid the horse's mane. Well, she always gets someone else. She hires someone else to do that work because she can't do it. And we've had a lot of OT work with the fine motor, but it's just not there. So this is her on the right-hand side in terms of her overall, and this would be an age typical, would be the green. It would all be filled in with green. The limbic area is particularly sad, with the huge needs for relationships with the opposite sex. She's just not had a good experience. She actually had was a sexual incest thing at 12 with a boy that she was kind of dating. So I'm sure that this limbic area is constantly vigilant, waiting for re-injury. And cortex, we're going up. You can see here to self-awareness, self-image. Oh, that's a pretty high level. And sense of time, delayed gratification. Remember the marshmallow, can I wait? No, she doesn't. She's fairly impulsive. And then here in the frontal area, she's made some strides, has completed high school at 21, but her ability to reflect, to really have a self, it's just very underdeveloped. And you can see the scale here from 1, 2, the bottom up to 11 and 12 at the top. So this is her current functioning level. So let's take a look at her QEEG, and unfortunately I gave her QEEG raw data to a hospital that was doing a workup on her, and they did not send it back. But these are some of the little raw assessments I did when I was working under, oh gosh, what's his name? The guy who's now down in Brazil. Help me. Anyway, I was doing basic assessments of just measuring the brain against itself. And these basically show eyes closed, left and right, eyes open, left and right, and then task left and right.
Is that Peter Van Dusen?
Van Dusen, exactly. Thank you. You've seen this before, Dr. Sitter. Thanks. And you can see the amount of alpha continues to be pretty high, although it does come down as she opens her eyes. That's nice to see in the frontal area. Not great, but here's the central area. Eyes open, eyes closed, eyes open, and then task conditions. And here's the alpha surging up. Looks like it's back. It's been a long time since I've looked at this. It's even hard to even look at it. I'm just so spoiled with your system, Dr. Sitter. But I do not have that data because I sent it to the hospital, which did a 3-day video and EEG workup, and they found nothing. They were looking for seizures. Here's the parietal area, and you can see the alpha continues to be the highest of all her brainwave patterns in the parietal. Here's the temporal. Some spikes of alpha with eyes open, especially on the right side, and with task. These are some of my notes. But let's go to her actual brain map now and see what the data was. And I would be curious, Dr. Suter, if this speaks to you. Looking at the alpha, of course, and the fact that she has a different kind of alpha, the theta ratio was not as important as the alpha to beta ratio. We did find that she qualified for auditory processing disorder, and I took her to Frank Musiak, who's probably one of the world's best in terms of teasing out very complex cases. And I thought it was so cool. We had her assessed with all the different assessments, including they imaged her brain stem to see if it had been damaged. I thought, how cool. So we did have a lot of workup on the auditory processing, and that got better. This was before that. Depressive disorder with an elevated central and left frontal alpha, low alpha. And a lot of problems with learning, which are here pointed out to alpha coherence and elevated alpha again, just alpha all throughout her brain. Visual, math, spatial, processing difficulties. And these are the recommendations. A whole lot of alpha down. And here's some beta in the OZ, CZ, C4 areas. And she was at a Brattleboro retreat, which is right there in Brattleboro where John Deimos hangs out his shingle. I took her in to see John Deimos, and she did some HEG, and this was his training plan for me. I thought it was interesting that he wrote out some interesting stuff, that he looked at her QEEG. This is where I first got an interest in HEG. 3-step protocol from Brown and Brown. Those are the folks in Pennsylvania, right? he was very aware of her inability to train for longer periods and that you needed to maybe take breaks during that 5 minutes. Remap after 40. And then he recommended a freeze frame, skin temperature, skin conduct, and test edge. This was a long time ago, but I was glad he was able to see her. Okay. I think I'm finished, and I'd love if anyone has questions, reactions.
I'm going to make sure everybody's unmuted here so that they can speak. I kept some of them muted because we're getting background noise. All right. Any questions anybody has about what we've been seeing? Well, I was impressed, Carl, with the way that they had broken everything down so carefully into a rating system, all these different dimensions. I mean, to me that was, since I'm always looking at that kind of thing myself, it was very impressive to see how they had conceptualized all of this into these 3 domains of sensory integration, self-regulation, relational, and cognitive. I think that's similar to the model that we've been using on the database system. We don't emphasize the sensory integration that much, but we have a sensory integration score built in. We just haven't posted it because we've been so busy. But other than that, the self-regulation with neurofeedback, looking at relational activities for the ISI, and the cognitive functions, I mean, those are areas that, major domain areas that we like to look at. So I can see how you would think that this would dovetail nicely with the map and the map systems you're using, or even the paradigm that we promote, which, the biopsychosocial paradigm.
She had had so many assessments at that point, and nobody really looked at the assessments with this incredible lens, and
yeah,
putting it all together, which was so valuable.
Well, Rob has shared with us that functional brain map key before, and it's been very fascinating to look at. But then you had a really detailed assessment. I don't know if you can bring that back up, or you.
Sure.
I thought it was pretty darn interesting at how detailed it was. And my question was, how did they rate the child? Was it a person rating them on tasks? Was it just observational ratings? How did they come up with those ratings?
Yeah, that again was a lot of review.
This is really kind of cool.
Everybody. Was this the one you wanted to see, or
Yeah.
is there a better one?
No, this is what I was talking about.
Yeah, let's see, okay.
That's a
So
fascinating
they interviewed everybody who had worked with her, all the occupational therapists, all the speech-language therapists. They interviewed everyone and looked at all the reports and then made their best guess. Again, this is current, right? Current central nervous system functionality.
Yeah, that is that's really brilliant. I like the way they did that.
So is the red and the pink and the yellow would be, it's like, where's that compared to the green, which is the normal?
So here we are, down here. Here's the key.
Okay.
Developed as green, light green, darker yellow,
Okay, so,
lighter yellow, pink, red.
So yellow is adequate, but as we get into the other colors, you're getting into it being inadequate or impoverished or underdeveloped. This is why we did years ago, Carl, when I was working in my other world, we did lots of trainings in expressive and experiential therapies, because talk therapy doesn't work well alone with this kind of kid. It just doesn't.
No.
You've got to get them moving and doing and get into their landscape and into, you know, how their brains and minds think, and get them doing things to get them engaged. And that's that whole chart I've shown with Pat Ogden's stuff, where they're either under-aroused, which you usually describe the girls as dissociative, they're in bed, the goal is to try to motivate them enough to get them into a therapy session, while the boys are all hyper-aroused and hyper-vigilant, and the goal is to try to get them calmed down enough to get into a therapy session. And when you talk to people working with these kids like I do, the boys in particular, you know, you start bringing up trauma stuff, and you say, so you start talking about trauma, and 5 minutes later the kid shuts down. That's it. You're done. You know, because the physiology kicks in when you start dealing with the trauma stuff, and it throws everything out of whack.
Well, so Carl, they just did all these interviews and investigations, looked at all the data, and then they filled out where it says client. They gave down those scores under current CNS functionality. They gave those scores. They were kind of a subjective assessment based on what they'd been looking at. Is that how it's done?
Well, again, you know, they interviewed current people who were working with her and saying, where do you see her? What skills do you see? And so they did a fair amount of you know, there was a lot of micro data gathering.
Got it.
She was working with an occupational therapist at that time, but, you know, the mother, me, I mean, we all gave information as to how we saw her, and then they sifted and used all the subsets of data from maybe 10, 12, 13 people.
Yeah. So they had some kind of rating system whereby they coded the data during the interviews.
Right.
I guess is what they did.
And they filtered that to sort of say, well, it looks like her relational attachment number is very, very low. She doesn't seem to get it. When other girls at the barn, I mean, she talked to the director at the barn that she was keeping her horse at, and, you know, how do you see her in terms of this? So they clarified little by little, and again, there was a rich amount of assessment. She had so many assessments during her high school time.
Yeah. Well, I think this is a fascinating model. I think that it would dovetail with mapping pretty nicely for a lot of these developmental issues. I like the categorizations. I think some of them don't really match up for me under brainstem and cerebellum. I'm not sure cerebellum would be sleep. I would put that under brainstem and reticular system function. So you know, there's some things that don't match up with, you know, my reading of the literature, but generally it does, and it's a really interesting way to rate it, and then to put it into a visual map like that is really brilliant. I think this is a fabulous job that this person's done working with this. You can tell how much time and effort he put into thinking it through.
A 25-page report and then 3 pages of recommendations that included a lot of somatosensory repetitive activities. And guess what riding a horse is all about?
Yeah, absolutely. Riding a horse is wonderful in so many ways, exercise, balance, everything. And it's a tremendously wonderful way to train a person, for sure.
Well, thanks for giving me the opportunity to present all this. It was actually interesting, too, to look at a high alpha brain, which she certainly presents at, a lot of 7 to 9 activity.
You have a lot of slowing.
Yeah.
Diffuse slowing. But, I mean, and that just indicates there's a lot of idling in the brain. A lot of areas are not synchronizing, and it may even indicate problems with, you know, mineral balances, sodium pump issues, things like that. So it is intriguing, and you do see that diffuse elevated alpha with a fair amount of kids with problems and like this. So that's fascinating that's what you saw on the map. I would really love to just see the plain map someday.
I know. Well, you know, it's interesting that she kept on having what they thought were seizures when she was working at PetSmart, and she would lie on the floor and be quivering, and the guy who's working with her says this is a trauma response. She's either highly sympathetic or highly parasympathetic. She has no middle road. So he nailed it, and yet the medical community, of course, had to do all their workup, so off we go to Dartmouth Hitchcock, and she's got the electrodes on, wired on for 3 days, and video cameras, and they didn't find any seizures, none.
Well, it's good to rule things out, though, too. You know, mainstream medicine is very good at a lot of times ruling things out. They just start to fall apart when you get down to the more fine-grained analysis.
Yeah. Well, thanks for letting me present this. I'm glad I could give you a little bit of background about how I got into this field and how exciting it is to work with a lot of kids similar and, frankly, less disturbed than my daughter.
Yeah, it's an interesting story. Interesting profile, interesting story. Yeah.
Yeah.
Hi, Carl, this is Honey.
Uh-huh.
Hi. First, I want to thank you for sharing your personal journey with your daughter. It was very moving to hear and see what you've been through to try to help her and support her. And what I'm wondering also is how you integrate this learning that you've gained from her, helping her into your practice, and what recommendations or suggestions you might have for the rest of us to integrate some of this in our work.
Well, we tend to be talk therapists, and even though we're doing this physiological model, I think more physiology. You know, I believe that breathing is really important. I believe that getting clients to be aware in a mindful way of their bodies and working, frankly, with OTs and PTs would be another wonderful way to really see headway. I mean, those people, I had a child with a shunt in his right brain. We did like 15 sessions. The mother's an OT, and she says, he's moving in a new way in his karate class. I've never seen him move like this. You're making incredible changes in the way his body is able to move. So to really get the correlation between seeing it in the real world, the physiology, changes in heart rate, changes in breathing patterns, I think more and not less physiology and less psychology is really the direction I'm moving in.
Well, this is Rick, so let me comment on the physiology.
Yeah.
Certainly what you presented earlier about early development is very consistent with PTSD and stress and all of that producing a lot of cortisol that is known to damage neurons in the frontal part of the brain and the hypothalamus and the hypothalamic pituitary axis for releasing cortisol and, you know, the whole adrenal axis. And then when you talk about breathing, you know that breathing is a stimulator. If you do deep breathing properly, you get, just like if you do aerobic exercise regularly, it decreases stress responses. It decreases sympathetic activation and increases parasympathetic activation, which all tend to decrease the slow waves, the magnitude of slow waves in the QEEG, primarily in the frontal regions.
It's amazing that I took a 5-day class in the healing power of the breath from Dr. Richard Brown up at Sir Paulo, and it was specifically all about that. He didn't give all the science behind it, but boy, when I do breathing with clients, the session's a lot better. And I use Respirate, but I think to really have them take it home, I give them a CD that has breathing exercises. And thank you, Rick, for chiming in on this. It's good to hear your perspectives on all the time.
So I agree with you 100%. The literature and all the research supports aerobic exercise, deep breathing, and everything you can do to decrease stress will improve her.
Okay, good input. All right, Carl. Well, thank you so much for presenting. This is a very fascinating model, very interesting. I'm sure other people will be interested in back channeling you and finding out more about it and how they might want to use it. So we will get together again on our usual Neuro at Night on Monday night at 7. I hope everybody has a great weekend. Thank you all for coming. I hope you all feel like you got something out of this. And Rob, you have anything to add?
Thank you, Carl, very much.
Okay.
Nope. Carl, that was great. Richard, I sent you and Dan both an email. The problem may be at my end, by the way, but I'll have you both take a look and see.
Yeah, we'll get
Carl,
together.
Great stuff.
We want to help.
Yep.
Okie doke. Take care, everybody.
Thank you. Good night, everybody.